Welcome to my presentation on schizophrenia. My name is Tom Paliaro. I'm a postgraduate student at Monash. So, schizophrenia is probably the most misunderstood of all psychiatric disorders. It is complex, yes, and disabling, and it impairs parts of human cognitive, perceptual, emotional, and behavioral functioning. 1 out of 100 people have it, which is a lot higher than I thought before I started preparing for this. And it usually have the onset during adolescence or early adulthood, and it has a deteriorating course. So patients with schizophrenia have a mortality ratio of 2.6 against patients without it, and most of these deaths are attributed to suicide and presence of comorbid physical conditions. In this 10-minute talk today, we're going to start with symptoms, then we're going to kind of follow the journey of a patient with schizophrenia, perhaps like the famous John Nash here, and through the various stages he might have gone through if he was born today. So we'll look at what we need to get a diagnosis, we'll look at how we rule out other diagnoses, and some of the controversies faced and what the future holds for this syndrome. And if there's one takeaway I'd love you to take with you, it's that people with schizophrenia are very functioning, just like John Nash here, won a Nobel Prize, husband, father. So some of those stigmas aren't quite true when we think about schizophrenia. Looking at the symptoms, in general, we've got positive, negative, and cognitive. So positive symptoms are the psychotic symptoms, so delusions, which are false beliefs, hallucinations, which is perceiving a sensation isn't real. This can be visual or auditory, or disorganized speech. So think of like a jumbled word salad, like saying stop, go, pencil, late. Doesn't make any sense. And then also disorganized or catatonic behavior. So it'd be like wearing a coat on a really warm day. And none of these are physiological. They're all in the mind. The negative symptoms are like basically just like a decrease in emotions. So you've got flat affect, not responding, that would seem like a response that would seem inappropriate. Like if you saw an elephant on your front lawn, just being like, whatever. Alegia, so poverty of speech. So if someone says like, do you have a family? You might just say yes, but probably most of us would say yes, I have a wife and 3 boys. And avolition, so that's just really just like feeling flat, decrease in motivation. You don't catch up with friends, you don't look for work, that kind of stuff. And then the cognitive, so these are more subtle and include you're not being able to remember things, learn new things, or understand others easily, and a bit more subtle. So moving on, let's imagine that young John Nash is going to see the doctor for some reason. Perhaps he had a psychotic episode the night before, or had one of the other symptoms, and he ended up in front of the doctor like any GP, and so any visit the GP starts with you just present what's going on, you ask a whole lot of questions, background tests, ask about your family history, mental illness, and probably here we could already rule out, so if we think of the differential diagnosis, if it was drug induced. So were you smoking marijuana all last night when it happens? And this could rule out schizophrenia. But if not, then we can run a lot more tests. And over the last several decades, a lot has been done to find out the etiopathophysiciology of schizophrenia, with variations in the localization and severity of brain impairments have been used to hypothesize that schizophrenia is made up of multiple disease entities. So we're really just figuring out a little bit of how this thing actually works. And of course, in an ideal world, each disorder will be in its own neat slot and will be easy to recognize a patient and treat it accordingly and not have to think what else could be going on. But the reality is that patients don't present with just exactly one thing. There's a lot going on, and they'll have multiple coexisting conditions. So we run tests to try and be sure as we can that it is what we think it is and not something else. For schizophrenia, the most common differential diagnoses that need to be considered are listed here. And as mentioned, for schizophrenia, it's in that GP visit and maybe even with a psychiatrist or psychologist that we can rule out some of these already. The diagnosis of schizophrenia is currently primarily dependent on clinical assessments, like psychiatry, history, and mental status examinations. But for some of the others on the list, we'll look at them as we go through the other tests. So probably first up, a patient will undergo a 1-hour neurology exam where the neurologist is looking for signs that correlate with schizophrenia. The neurology test is direct, it's easily administered, and an inexpensive way of investigating brain dysfunction in schizophrenia. So neurological abnormalities include both hard and soft signs. So hard signs refer to impairments in basic motor, sensory, and reflex behaviors. In contrast, Soft neurological signs include deficits in sensory integration, motor coordination, and sequencing of complex motor acts. Soft signs are more prevalent in schizophrenia patients compared to healthy people, and this really supports the assumption that they constitute a very intrinsic feature of schizophrenia, which is why we do this test in the first place. So from a clinical point of view, they really help us to monitor the disease's process and help with that diagnosis. One weakness is that, of course, yes, it's only correlational, and recent studies have shown that these soft signs are not even static, but they're varying the clinical course of the disorder. So, it really makes it a bit tricky to really read too much into it. It could forever help us rule out Wilson's disease, which is an autosomal recessive illness, and the first symptoms of that include the appearance of odd movements. Moving on, neuroimaging. So CT, maybe MRI, but probably just CT scans have been used, again, to rule out organic causes of schizophrenia and disorders that cause secondary psychosis, such as mental illnesses and substance abuse. So what can they find? So brain structural abnormalities are widely reported in schizophrenia, with a lot of large-scale meta-analysis detecting smaller hippocampal volume in patients, better controls, smaller amygdala, thalamus, nucleus accumbens, and intracranial volumes, as well as a larger pallidum and lateral ventricle volumes. Also, the superior temporal gyrus can be reduced in volume, and this could explain the catatonic behavior and problems with language. And so if we see these things, then we know it's more likely that the person has schizophrenia. And so that's one reason to do it, and also helps us just better understand the syndrome, where it comes from, and helps us with treatments as well. But even if these are all present, they only correlate. We can't operate or anything like that. We can only treat it with therapy and medication. And Lubin said in a 2002 study that only 30% of all brain scans of schizophrenia patients are reported as abnormal. So this really suggests that the routine use of brain scans to rule out neuropathology in psychotic patients may not actually be cost-effective or useful in the diagnosis. So moving on, neuropsychological testing. This is very important, as its function is frequently observed in schizophrenia patients with deficits in memory and learning, working memory, executive functions, attention and processing speed. And some of the tests are listed here, and they would play a big role in ruling out other disorders, perhaps such as personality disorders, using the Wisconsin card sorting test or other tests. Some studies have shown that only 70 to 80% actually have a cognitive impairment. Some even just found 55%. So again, although these tests are important, some people don't have normal cognitive abilities. So again, we can't read so much into these tests, but it does all help narrow it down with other possibilities. And of course, cognitive deficits are present in all psychotic disorders, but are most severe in schizophrenia and least so in bipolar manic disorder. So again, this could help rule out bipolar manic disorder. So here we go. We do all these tests, we ask all our questions, we monitor the patient, and then we try to see if we can classify them with a diagnosis of schizophrenia according to the DSM-5. So to get that, you need two of the following: delusions, hallucinations, or disorganized speech, disorganized behavior, two of them, and at least one of delusions, hallucinations, or disorganized speech. You also need the symptoms to be ongoing for at least 6 months, and have 1 month of an active phase symptoms. So where are we at? There is actually a big push to suggest that schizophrenia is not even a distinct disease, and we really need to rethink and start again with this thing. Similarly to the concept of autism spectrum disorder, we don't have Asperger's anymore. We now see it as a spectrum because people experience it so differently. So it's argued now that it should be just called, psychosis, and just seen it as a continuum and in degrees, with schizophrenia at the severe end of that spectrum. One term that's been suggested is to call it psychosis spectrum disorder. And the Japanese have already renamed schizophrenia as integration disorder. So it could become one thing of the past. And that's also because of the stigma in society around it. One quote I think that kind of wraps up where we're at with this is by Sir Robert Murray, psychiatrist. So given these points, on top of the stigma that already exists in society, I think it's really important that we listen to these new ideas and do our best to help those suffering with this incredibly tough syndrome. Here are my references. Thanks very much for listening. Have a great day.